hospitals. Other factors include family dynamics, the surrogate's own feelings of guilt or feelings of loyalty with respect to the relationship to the patient. Some surrogates just feel that they have to do everything, right? They just subscribe to the so-called technological imperative. There's a significant belief in miracles, which is fueled by high-profile stories like those in Sanjay Gupta's book, or the Belgian man who was allegedly conscious during his 23-year coma, or now studies about using fMRI with PVS patients. And too often, surrogate expectations are also fostered by conflicting messages from different healthcare providers. But finally, it's easy for surrogates to act on all these reasons because the costs of their decisions are externalized, right? The costs are often borne by an insurer, and the guilt and distress are pushed off onto the nursing staff. Surrogates request continued treatment because it's called for in the religious or cultural tradition. Only God can give and take life. It's not my choice, it's not the doctor's choice. And go back to the Archives of Surgery study. Question: if doctors treating your family member had said that futility had been reached, would you believe that divine intervention by God could save your family member? Nearly 60% said yes. Religion is the most significant factor in the most intractable disputes, right? So of the subset of futility disputes that are the most difficult to resolve, that don't get resolved, religion is the most significant factor of that subset. So that's why surrogates demand treatment. Why do providers resist? Why don't they just give the surrogate what they're asking for the patient? And so, again, as a stop, take a quick poll. Professional integrity. They want to avoid patient suffering. Stewardship, right? Stewardship, rational use of resources. They distrust the surrogate, right? They don't believe that what the surrogate is asking for in terms of treatment for the patient is what the patient would have wanted, or to avoid staff's moral distress. So just stop and take a quick pulse here of okay, so patient suffering, far and away, the reason one would resist a surrogate demand for what they consider non-beneficial treatment, followed by resources, followed by professional integrity. In fact, I think that's where I was going to go, which is, I think the most significant reason at the top of the list is the provider's desire to avoid being complicit, right, being engaged in causing suffering, right? In one case from Canada, the physician described the surrogate requested treatment as an abomination, as immoral, as tantamount to torture. Another recent case at the Mass General, they said this is the Massachusetts General Hospital, not Auschwitz, right? They're equating the requested treatment to torture. And providing such care is a significant cause of moral distress. We had the poll that we did earlier that showed that. It's the most, in fact, study after study shows it's the most significant source of moral distress among the nurses. Providers want to defend the integrity of the medical profession, right? They're not indentured servants, reflexive automatons, or vending machines. And this is an important one, I think. Providers want to do what they think the patient herself would have wanted, right? They doubt the surrogate decision reflects the patient's wishes or preferences. And the data do suggest that surrogates are not very accurate. Many studies. And they're not just inaccurate, but they're inaccurate in one way. They're inaccurate in the sense that the surrogates are far more aggressive than the patients would have been themselves. And finally, providers do want to be good stewards of healthcare resources, both hard resources like ICU beds and even soft resources like healthcare dollars. So surrogates demand providers resist, right, that creates the conflict. The volume of conflict is rising, among other things, just because of the growth of the elderly population, and they're the most significant population involved in these disputes. But there's reasons that not just the volume, but also the rate of conflict is increasing. Surrogates are more likely to demand, providers are more likely to resist. Why? Surrogates are more likely to demand. In this Pew Trust, this is just one survey of many similar ones. In 1990, they were asked, would you do everything? When people were asked, should we do everything to save a life, 15% said yes. In 2005, 15 years later, 22% said yes. The same sorts of things are duplicated again and again. This is a study that's just published in the Journal of Medical Ethics. 23% agreed strongly or agreed that if I were severely ill with no hope of recovery, I would want to be kept alive at all costs. Right? These numbers are much higher than they were 10, 15 years ago. Same thing in California, 23% always do everything possible to save a life. And at the same time that surrogates demand more, providers are less likely to accede. So this number that we talked about before, the 44% of physicians who would say that patients have a right to demand care that doctors think will not help you, there's reasons to think that that will go down. There's more palliative care training, more emphasis on palliative care, more end-of-life training, more of an emphasis on provider rights, and shifts, or at least impending shifts in financial incentives. So we looked at the definition, we looked at the causes of medical futility disputes. Now I just want to look at the typical resolution pathway. But first, let me just, again, stop, quick poll, 50 seconds. How do you see futility disputes typically resolved? That the surrogate eventually agrees with the healthcare provider, that the healthcare provider caves in to what the surrogate is asking for, even though they don't think that that's appropriate, or that the patient dies, during the course of the dispute, or that the patient is transferred to another provider or institution that's willing to provide the treatment. So the green is number 2, healthcare provider accedes to the surrogate demands. It's 23%. 40% is surrogate eventually agrees. So that's the biggest. Surrogate eventually agrees, 40%. Healthcare provider accedes to surrogate demand, 23%. Patient dies, 32%. Patient transferred, 6%. So I think it's important, even though I'm a lawyer, right, that the lawyers often aren't relevant, and that's good. Well, I teach at a law school, and I have a whole classroom of students who all need jobs. But I think it is good news that communication and mediation usually work, okay, in most disputes of this type. Prendergast showed, right, that 57% of surrogates agreed immediately, 90% within 5 days, right, and so there's only this 4% rate of intractability. In a more recent study by Garros, same thing. First meeting, 50% consensus. Second meeting, 70%. Third meeting, 90%. But there's still a small rate of intractability, but overwhelming consensus. Fine in Mayo, same thing. And finally, in a really large study of Texas futility disputes, of nearly 3,000 futility disputes, consensus was reached in all but 65, right? So that's just a 5% rate of intractability. And there's reasons to think, right, that even this resolution, this consensus, could be increased with training like provided by LNEC and EPEC. And given this kind of data, it's wholly appropriate that the first 4 of 7 steps in the AMA's model futility policy are all aimed at communication and mediation, right? So the first 4 steps: deliberate and negotiate, joint decision making, involve consultants, involve the ethics committee. Only in the rare case do you need to move to step 6 and 7 of the AMA model policy, try to transfer the patient, and if you can't transfer, then the intervention need not be offered. So consensus is reached in almost all the cases, almost all the time, but what I want to focus on is this range, the subset of intractability. It's for these that we want to employ formal policies or the formal mechanisms provided in the law. And so let me just give a quick roadmap of the next section I want to get to here is we'll look at just the nature of intractable conflict, look at court cases, and then look at 4 different legislative approaches that are in the United States. So intractable conflict. And I might note that while we're talking about only this 5% of intractable cases, that the resolution of those matters not just for that 5%, but it really matters also for the other 95%, because the law casts a shadow in which all the other cases are resolved. Just a quick example, right? If the law said that surrogates had the right to demand treatment, then some surrogates might be less likely to accede to surrogate demands. Sandy Johnson, now the dean at St. Louis University School of Law, identifies medical futility as one species of, quote, bad law claims. And the term bad law is apt because it describes law that physicians claim forces them to do bad things. Their professional training says do A, but there's legal risk in doing A. Or at least there's a perception that there's a legal risk in doing A. So physicians are chilled from doing what they think is right for the patient.